Good evening. Welcome, Professor Nagaswamy sir, and my dear students. Welcome you all to another session of PESA DNB Academic Activities Online. Today we have again second session of rapid discussion. Sir will be discussing on long cases. Over to Professor and students, please.
Thank you. Did you all find out any cases missing in the short case discussions?
No, sir.
No, sir. Almost all covered, sir.
Almost all covered. But I found out 3 cases of difficult airway not discussed. Of course, the other difficult airway we discussed about cleft lip and palate.
TMJ ankylosis, sir.
TM joint ankylosis and
Laser
TA oral
surgery.
cavity. TA oral cavity, especially malignant growth in the lip and cheek or tongue, malignancy in the tongue, which all cause difficult intubation or airway. That was missing. All other things mostly we were able to cover. And during the last class, we just gave the picture or the scenario and immediately made a diagnosis and then went on to discuss how to manage and what are the important problems. That is the way the short cases are also discussed in the exam, as you would have experienced when attending your previous PAT exams or other model exams. Whereas long case, they give you a longer time duration, at least 30 minutes or 20 minutes to elicit the history and then examine the patient and then make your diagnosis based on the patient's complaints and your findings, and then the discussion will start. So I thought we will have to discuss all the long cases that are commonly kept in the exam in the same way. And so with that introduction, I would like to go ahead and share my screen with you. I have managed to make a list of about 19 cases so far. And these 19 cases, I first thought I will go in a serial order. But after preparing the PPT, I found that some topics are little gray for the students all the time. And so they may require a little bit more elaborate discussion for the purpose of understanding the topic better, as well as presenting your making your presentation in the examination also. So 2 such topics I found was, one is obstructive jaundice and another is anemia complicating pregnancy. So these 2 topics will be discussed a little in a larger perspective, whereas the other things all will be just a random pattern of starting with the case scenario will be given. Then first thing will always be, as I have been telling you, to do the analysis of the case or make a study about what are the challenges or the problems that you have in that case. Then go on for history taking, then physical examination findings, then it will be pre-op investigations and risk stratification, then it will be your pre-op instructions and optimizations, then it will be intraoperative management, post-op complications. So this is the series of headings under which all the topics will be discussed. So let us go straight to the presentation and see how to manage that. So the order will not be in a serial fashion. It will be little jumbled up, and as you can see, I put another case as the starting case of number 1, but then I changed the order, and now we are getting case number 2. And the case says 72-year-old lady who is a homemaker complains of chest pain on and off. And the pain is retrosternal, associated with exertion and palpitations. Seen by cardiologist, advised investigations and to proceed. She has gallstones and she is advised lap cholecystectomy. Okay. Now the first question is, analyze the problems in this case. All of you have to answer. This is not
elderly lady with like probable a CAD patient. So CAD risk is there.
Okay.
Then planning for a laparoscopic cholecystectomy.
Yes.
Laparoscopy itself can cause a stress.
Stress, very. It has also its own physiological intrusions like carboperitoneum, which can have a lot of cardiovascular implications. Okay, very good. So the analysis starts with the 72-year-old lady. She belongs to the geriatric age group. Okay, and she complains. Her complaint suggestive of ischemic heart disease, retrosternal pain associated with exertion and palpitations, and needs for lap surgery with its effect on CVS and RS physiology. Okay, so these are the three important points that you get from this particular case history. So what are the most important history to be elicited? Once you start taking the history taking, when you do the history taking, what are the things you will ask the patient?
Main primary complaint why the patient has come for the hospital. Is it a gallstone induced abdomen pain or a gastritic pain and led to a chest pain on and off? So we should
distinguish between a cardiac pain and an abdominal pain. Okay.
Abdomen pain.
Right. You can summarize like that. Very good. Then.
His daily activity myths.
Effort tolerance. That is a very, very important thing that you have to ask. So chronological versus biological age. Always, whenever you get a geriatric age group patient, you decide whether according to the age he has aged. Some people, as I have told you in the earlier class on geriatric anesthesia, the patient may be saying he is 80 years old, but his activities, his fitness, his reflexes all may reflect as though he is only 60 years old. He may be so brilliantly active and agile. Whereas a person who is only 60 may look like a 80-year-old stooping, with no interest in life, with lot of complications. So always distinguish between the chronological and biological age. Then age-related changes in CVS, RS, renal, GIT, gut, musculoskeletal, all this too has to be elicited. And with regard to CVS complaint, where you suspect there is a IST, duration of chest pain, factors aggravating and relieving, medications used and prescribed, and because she has here it says she has been seen by a cardiologist, and so some medications could have been given, and what is the meds or effort tolerance. So these are all the important points. I'm not talking about the entire history because we have to discuss all the cases. I'm just giving you the important points which you should not forget to elicit in the history. Now, what important points to be looked for in the physical examination of the patient?
Her effort tolerance.
Okay, physical importance, effort tolerance.
Her BMI, sir.
BMI.
Signs of cardiac failure.
Failure, chest pain failure. Okay, then because this is a ischemic heart disease, so all the things which are relevant to risk you have to stratify.
So airway examination, bedside pulmonary function test.
Pulmonary function for an ischemic heart disease. Okay.
Since she's
so
a
general
72-year-old,
examination, it should
yes.
include airway, CVS examination, pulse for arrhythmia, heart size, sounds, BP both lying and standing. To rule out any autonomic or postural hypotension. Then What pre-op investigations and optimizations are needed in this case?
So, ECG and
ECG.
stress,
Complete,
stress,
First of all, a
stress,
basic resting ECG.
complete blood
ECG
picture.
and echo, sir.
ECG echo. And if ECG looks normal, but patient complains of chest pain, then you have to do a stress echo.
Stress.
Already ECG has any evidence of ST depression or elevation indicating some ischemic changes, then an echo will be sufficient. On the contrary, the ECG is absolutely normal with sinus rhythm, and echo is also not very contributory, but still the patient is complaining of retrosternal pain on exertion and palpitation. Then you have to rule out inducible ischemia. So that can be done only by a stress echo or a stress ECG. Okay, so if the examiner asks you why you want to do a stress and the ECG is already showing ST elevation, then you have no answer. If there is an evidence of ischemia already present in the resting ECG itself, then there is no need to do any stressing. Whereas if the resting ECG is normal and echo also does not show any regional wall motion abnormality, then only stress ECG or stress echo is indicated to find out whether it can be induced by exercise or effort. Okay? So preoperative investigations and optimization. What are the routine investigations you do for surgery? Then evaluation of chest by ECG and resting ECG. Nil significant, then go for stress EKG or stress echo. And coronary angio. Only when it is definitely indicative of an ischemia or already mild infarction which is ignored, then patient will require a coronary angio with treatment based on the results, whether to go for medical management or intervention. Yeah? And sometimes if the condition is very severe, the block is quite severe, which is not amenable to medical management, then you have to insist on patient getting a PCA or a CABG and plan surgery based on the type of treatment recommended for CAD. Because if you miss a severely blocked coronaries by your investigations and take up the patient for a non-cardiac surgery, what is the most important risk or complication that can happen? The patient is complaining of ischemic chest pain, and ECG shows a mild variation, and you have not thoroughly investigated by angio and other things, and you do a lap cholecystectomy. Then what is the risk that can happen in the post-op period?
Perioperative MI and cardiac.
Perioperative MI, yes, immediate on the post-operative time, you can have a perioperative MI that will cause a problem of perioperative death is very, very common if not diagnosed correctly in the preoperative phase. Okay, so this is the important point that you have to remember. Then how do you do the risk stratification?
Sir, we have to see whether it is a high risk surgery or a low risk surgery, and how is the patient's effort tolerance.
Somebody has done a work and given you the points
Revised
for
cardiac risk index.
Immediately whenever you have a ischemic heart disease patient, don't forget to mention this. Please revise cardiac risk index. Okay, this is the immediate answer that should come in the examination. Okay, so what are the points that you have to remember in Lee's revised cardiac risk index?
History of ischemic heart disease.
First and foremost is the type of surgery, isn't it?
Okay. Yes.
Start with the type of surgery, then second is the presence of ischemic heart disease. Third is
congestive cardiac failure.
whether already patient is in congestive cardiac failure. Fourth is
stroke or TIA.
Any central nervous system effect like stroke or TIA. Fifth is
preoperative insulin therapy for diabetes.
Patient or diabetic patient requiring insulin. Sixth
and
is
serum creatinine more than 2 milligrams.
renal involvement. Okay, so these are all. So always start with the type of surgery, then go to the two cardiac problems like presence of ischemic heart disease or congestive cardiac failure. Then go to the central nervous system effect like stroke or TIA. Then go to the renal problem like raised creatinine. Then go to the metabolic problem like diabetes with requiring insulin. So remember that in that order, then your presentation also will look good instead of jumbling up for starting with the ischemic heart disease and saying the type of surgery as the last point. So go in a sequential order one by one. That presentation will look better. What is the pre-op advice and pre-medication?
Informed high risk concern, sir.
Informed and high risk consent. Okay. That is based on the supposing Lee's revised cardiac risk index is only 1. Still, do you have to get a high risk consent? What is the percentage of mortality based on the Lee's revised cardiac index?
3%.
0.5%.
One risk is about 1%.
1%.
Then 2 it goes to 5. Then it's 3 it goes to 7. Like that it goes on increasing, isn't it? So based on that you have to get the consent, and it's not always a high risk consent for every ischemic heart disease patient. Okay. So what are the other advices you have to give? Supposing she has been prescribed some medications for this ischemic heart disease, what are all the drugs that she should continue? What drugs she can stop on the day of surgery? That is a very important pre-op advice always. And next thing you will advise is about this NPO guidelines. Okay, so pre-medication consists of anxiolysis, antacids, continuation of medicines prescribed for CAD. This is the usual pre-medication. And pre-op advice will be always to how many hours of starvation, and if the patient is a diabetic, what are all the modifications they have to do with their anti-diabetic drugs. So all those things you have to tell in the examination. What is the plan of anesthesia?
General anesthesia with endotracheal intubation, sir.
Intubation, very good. What about the pain relief? Just a simple endotracheal intubation anesthesia will be sufficient.
So we can supplement with intravenous
in other
opioids.
words, whenever you plan for an anesthesia in a patient with some cardiac ailment, you should set your goals. What are the goals you want to achieve to make the heart function well without going in for further ischemia?
Avoid hypotension and tachycardia, sir.
Okay. Any cardiac case, I have told you the mnemonic CRRI, PACRRI. What is the mnemonic PACRRI standing
Adequate
for?
preload.
Preload,
afterload, contractility, rate, rhythm, and ischemia. Okay, so any cardiac case, whether it is valvular heart disease, whether it is congenital heart disease, whether it is ischemic heart disease, always keep this in your mind. So what should be the preload? What should be the afterload? What should be the contractility? What should be the rate? What should be the rhythm? And how to avoid intraoperative ischemia? These 6 points you have to always, even though you don't tell this mnemonic in the examination, this is the way you practice to present, so that you will be able to know how to manage this case. So plan of anesthesia, a combined GA and a regional technique will be much better, because simple GA alone will not guarantee 100% pain relief. So when pain relief is not complete, what can happen?
Itself can trigger
Increases the demand.
That itself will increase the sympathetic system. It will increase the heart rate. It will increase the blood pressure. That will always increase the oxygen demand on the myocardium, and intraoperative ischemia or infarction itself can be precipitated. So our goal is to maintain supply demand to the oxygen myocardium. So adequate preload, normal afterload, low or slightly reduced contractility so that the oxygen demand is reduced, avoid arrhythmias, maintain sinus rhythm, preserve coronary artery perfusion pressure. What is the coronary artery perfusion pressure? How do you calculate the coronary artery perfusion pressure?
The end diastolic pressure minus LV end diastolic pressure.
Is it the other way? End diastolic pressure minus aortic pressure, or it is the aortic?
Yes, sir. Yes, sir.
It is the end diastolic pressure minus, or the diastolic systemic diastolic pressure minus the aortic pressure. Okay, that is how you calculate. So your the maintenance of diastolic pressure is very, very important for coronary perfusion. So if there is a drastic fall, especially after a subarachnoid block, single block for in a coronary disease patient, if the BP, starting BP is 120/80 and it falls to 90/40, your coronary perfusion will be very badly affected because it depends on the diastolic blood pressure minus the aortic pressure. Okay, so that is how the perfusion is happening only during the diastole. So if the pressure drops, then your ischemia will be precipitated on the table. So that is also an important point that you have to keep in mind. And so after this plan and the goals, you describe the correct intraoperative management. How do you, now we have planned that we'll give a general anesthesia with regional. Now for intraoperative management, we have to sort out what are all the drugs that we are going to use for induction, for intubation, for maintenance, for analgesia, for recovery. Like that, intraoperative management should consist of the drugs that are safe to be used in a patient with coronary artery disease. So what is the induction agent of choice?
Etomidate, sir.
Etomidate is ideal, very good. Then propofol.
The titrated doses of propofol with minimal sevoflurane induction can also.
Why combine both? What is the idea of combining sevoflurane also along with propofol?
Use the requirement of propofol.
Propofol, okay. Any advantage in using sevoflurane? Your idea is good. Your plan is logical. What is the advantage of using an inhalation agent?
It gives an additional advantage of reducing the sympathetic response, especially during scopy, sir.
No. Anybody else?
Sir, in isoflurane, we can have coronary steal phenomenon, which helps.
Coronary steal phenomena is prevented or it is there? What is coronary steal? Now that you are committing yourself, when you say, whenever you say something new, you should be able to explain. What is coronary steal?
It is a misnomer, sir. Actually,
Ischemic area will get a lesser blood supply when compared to the normal area.
non-perfused area.
Normal area. So whenever there is a dilatation, the normal vessels will be able to dilate. Because the ischemic area, the vessels have already dilated to the maximum because of the blockade. They cannot dilate further. So whatever blood is being going to the ischemic area so far will also be diverted to the normal area because of the caliber of the normal vessels will increase manifold compared to the caliber of the ischemic vessels. So the normal area will get more blood supply, which is not required for that, and the ischemic area will suffer more from want of blood supply. This is what is called coronary steal. Okay, so isoflurane is supposed to prevent that. It will not cause excessive dilatation of the normal vessels, so that whatever already present blood flow to the ischemic area will be sustained or maintained, so that further deprivation will not happen. Okay, this is the clear concept that you should have about coronary steel. Okay, but that is not the reason why you can use an inhalation agent. What is ischemic preconditioning?
Sir, there will be a condition which mimics ischemia and which has the blood supply to the ischemic area before
Exposing the myocardium to physiological stress before it itself
Short
undergoes.
spells of ischemia will make the myocardium withstand longer duration of ischemia. That is all the simple understanding of ischemic preconditioning. Short spells of ischemia will make the myocardium adapt itself to longer duration of ischemia. That is the meaning of ischemic preconditioning. So your volatile anesthetic agents are supposed to help in doing this, what is called the ischemic preconditioning, which will help in the prolonged ischemia, even if it happens, preventing a full-blown myocardial infarction occurring. Okay? So in that way, a combination of titrated doses of propofol with inhalation of sevoflurane, but with a guarded monitoring of the blood pressure, especially diastolic blood pressure, is very, very important. Okay, so that also can be. So intraoperative first of all, you have to monitor intraoperative management. First, you always talk about the monitoring. Apart from the regular monitoring, any ischemic heart disease patient coming for non-cardiac surgery, it is better to go for this configuration, what is called the CM5 configuration, to detect any intraoperative ischemia or infarction. What is this CM5 configuration? I have
it
shown
has
you
a
all the
12
slides and pictures of this CM5 configuration in the class.
it
When
has
we
a
talked
12 lead
about.
ECG monitoring.
Huh?
It has a 12 lead ECG monitoring.
Is that called CM5? See, the clue is in this. Central manubrium, that is the expansion for CM, and 5 is the V5 position of the lead. Okay,
Yes.
so if have you ever gone and watched how they take an ECG for a regular patient with all the attachments, apart
Yes, sir.
from the normal ECG that you monitor with the OT? When they take a ECG for a patient in the outpatient department or in the cardiology department, they put some clips on all the 4 limbs. Have you ever gone and seen that?
Yes, yes,
Yes,
sir.
Yes. And then they put a cup-like thing on the chest in 6 positions, one to the right of the sternum, then 5 cups on the left of the sternum, isn't it? So they all indicate V1, V2, V3, V4, V5 positions. So that has to be done. So the right, whereas in the OT, what you do is you put a 3-lead ECG, you put the right shoulder or right chest electrode on the manubrium sterni, and you put the left shoulder or left arm electrode on the CM, that is V5 position, that is over the apex, and the left leg electrode will be on the same position. So instead of putting it on the right arm, and left leg, if you put the right arm in this manubrium sterni and the left arm lead on the V5 position on the chest and the left leg in the same position, that is called the CM5 configuration. Okay, and this will detect intraoperative arrhythmia better than your normal right arm, and left leg position of electrode placement. And you may have to go for IABP to monitor the blood pressure in cases of severe diagnosed ischemic heart disease in the preoperative phase. Then you can go for a careful titrated induction with propofol, etomidate. Then the intubation can be done with acronium or cisatraconium and prevent hypertensive response to laryngoscopy and intubation with a quick endotracheal intubation lasting less than 15 seconds. And you can give a pre-treatment also with the usual drugs like, what are the usual drugs we give to prevent the hypertensive response?
Lignocaine, esmolol, and opioids, sir.
Don't you use Xylacard?
Lignocaine, yes, sir.
Lignocaine
That is the
1.5
first drug. Always it is safer, you know, it will prevent arrhythmias. At the same time, it will prevent the hypertensive response also. So always start with Lignocard, then you could talk about esmolol or NTG, whatever drug you want to. So don't forget Xylacard.
Yes, sir.
What is the dose?
1.5 mg per kg. Sir.
1 to
1 to 1.5 mg, sir.
1 to 1.5 mg per kg. Okay. And you have to wait for 90 seconds after injecting the drug. Don't immediately go for that. And maintenance with inhalation of CO, isoflurane in air or oxygen, air and oxygen. And analgesics that you can think of are fentanyl, morphine plus para or NSAID. IV lignocaine is also being recommended now. And port site infiltration before the ports are introduced or the scope is introduced at the port sites with 0.25 bupivacaine, and intraperitoneal installation at the end of this procedure with 20 ml of 0.25% bupivacaine. Okay. All these things are the LA or regional techniques for this particular surgery. Nowadays, what other plain blocks we can use for this procedure? Lap cholecystectomy.
Tap block, subcostal tap block,
Subcostal
bilateral subcostal tap block is the ideal one which is being recommended. And reverse the effects of the non-depolarizing muscle relaxants with titrated doses of neostigmine, not the regular 5 ml of myopyrrolate that you normally give for all patients. Titrate and monitor the recovery and stop. Why you have to give only just the required dose of neostigmine and not the regular entire 2.5 milligram?
Radiant hypotension common in neostigmine.
Post-op leg delayed bradycardia and hypotension can happen in the post-op period. Okay, so that is the reason why we have to give this in a very titrated fashion. And again, prevent extubation sympathetic stimulation also. Again, for that you can repeat the same Xylacard which you are given during the initial endoscopy and intubation. Okay, what is the post-op care?
monitor ECG. And
Monitor in a high dependency area. Which time of the day or night is very, very important in patients with ischemic heart disease undergoing any non-cardiac surgery?
48 hours to 72 hours.
What is the time they develop normally an ischemic attack?
48
the
hours to
first
72 hours.
That is the total duration. But I am asking you about the particular time of the day or night.
Early morning.
It is in the Brahma Muhurtam time, between 3 a.m. and 6 a.m. Why?
the pain
Catecholamine releases during that
time.
Vertical?
catecholamine release.
Catecholamine release is maximum in the time when they are sleeping early in the morning, is it?
Yes, sir.
Yes, sir. When you are mentally sleeping, will it be with the maximum release of catecholamine? Okay. Okay, think over it. I will tell you at the end of the class if you are not able to find out. Prevent pain, which can cause tachycardia, shivering, which will increase oxygen demand. These two are very, very important to prevent a post-op ischemic attack, and also monitoring at least for 48 to 72 hours, especially in the early in the morning. That is the time that usually the ischemic attacks happen. Okay?
And DVT prophylaxis, sir.
DVT prophylaxis, won't you be ambulating a lap patient immediately? It is not a routine thing. You know, if for long surgeries where patient is going to be bedridden for at least 48 hours, then you think of DVT prophylaxis. And these patients sometimes maybe would have been on antiplatelet agents in the preoperative phase itself. So the DVT is not a big issue in these patients because this is a daycare procedure mostly, and patient will be After surgery, within 2 hours, you immediately make them get up and sit in the chair and make them walk, isn't it?
Yes, sir.
So the risk of deep vein thrombosis is not there. And normotension, specifically diastolic pressure, supplemental oxygen, continuous CVC monitoring, rarely DVT prophylaxis in the obese or in other patients who had a previous history of DVT. That is this is the specification that you have to give here. And early ambulation and oral intake. Okay, all these things are the post-op care that you have to think of. So I have not dealt the whole thing that has to be told in the theory class as we discussed in ischemic heart disease. But here it is mainly the exam point of view. The questions are just like random questions which are asked in the examination. So like ischemic preconditioning or the hibernating or stunned myocardium, all these things are the terminologies that may be asked in the examination. So you have to keep it in mind. So this is the way the random discussion goes on. Questions are asked randomly without any order or the justification like in a theory class or a discussion where we go step by step and then discuss each and every point. Okay. So this is just like a practice for you to randomly think and answer. So any points or any questions that you want to add that discussion on ischemic heart disease? Okay. If nothing is there, we will go to the next discussion. 32 years old working woman complains of progressive breathlessness on mild exertion, cough, unable to lie on her back at night. And she gave history of fever, fleeting joint pain during childhood. Now she requires a breast lump excision. How to anesthetize? So as usual, the first point is to analyze the case. So what is the points that you can get from this case scenario given here? Of course,
Fever,
just to
fleeting
make sure
joint
that
pain
we are
during-
discussing all that, I have given a small clue in the questionnaire itself.
Rheumatic heart disease.
Rheumatic heart disease patient. Okay, very good. So the analysis complaints of suggestive of rheumatic valvular heart disease of moderate severity because patient already has a cough, unable to lie on her back, and the fleeting joint pain during childhood. All these things indicate that it could be a rheumatic valvular heart disease with severity. Since the patient is giving history, which is indicative of some mild congestive cardiac failure. But the surgical procedure is a minor one, suitable to be done as a daycare procedure. Okay, these are the points that you can get from the case scenario. What history to be elicited? Once you know it is a rheumatic valvular heart disease patient coming for a non-cardiac surgery, what are the points in the history that you have to elicit?
So since she has a history of fever and fleeting joint pains earlier in childhood itself, she might be on penicillin
Okay.
injections, tablets.
In what way? Yes, this is important, but in what way it is going to affect your management? Why you want to know whether she is on penicillin or not? First of all, won't you like to find out whether she already knew whether she had a rheumatic heart disease or rheumatic fever? Because she is 32 years old woman, she can give you all the details. So you can inquire about how the fleeting joint pain, at what age it occurred, whether it was preceded by a throat pain. Because examiners suddenly go on to ask all, I have told you in the discussion on mitral valve cases discussion, the question may be entirely on rheumatic fever itself. Instead of asking about the pathophysiology in mitral valve. Isn't it? So you have to make sure that the whether it is really rheumatic history taking, general examination, and whether it was rheumatic fever really that happened, and whether the patient has any still some residual effects. What are the residual effects of rheumatic fever?
Joint pain, sir.
Joint pains may still be continuing. Okay, that is an indication that it is not completely gone. Even though it is an autoimmune self-limiting disease, it may still continue. And that means why you are worried about the residual rheumatic fever? Because
So
the
active
pathology in the
infection.
heart will be still active. It can develop anytime an endocarditis, vegetations may be going on. But once all the rheumatic features have stopped after the age of, say, adolescence, about 18 to 20, that means the insult on the heart will also be stopped. On the contrary, patients who continue to have the joint pains and other on and off fever and all those things, the pathology in the heart will be still going strong, especially when you plan for a mitral balloon valvuloplasty. If the residual rheumatic fever is still there, even after you do the valvuloplasty, the pathological process in the valves will be still continuing, and within a matter of 3 to 6 months, the valve will again become narrow and become stenosed. So you have to make sure that there is no residual rheumatic fever activity in the patient. And what is the effort tolerance? Because already she says she's having cough, she's unable to lie down, which indicates some amount of failure. And history of paroxysmal nocturnal dyspnea. This is a very, very important feature. Why?
It is an indication of high left atrial pressure.
Left atrial pressure and failure. Even if otherwise the patient has a good effort tolerance, even one single attack of paroxysmal nocturnal dyspnea indicates that the myocardium is not fully compensated. It has a feature of failure. And features of right heart failure, like what are the features of right heart failure?
Increased jugular venous pulse.
Starting from JVP, hepatomegaly, fetal edema. Okay, so like that you imagine all the features of right heart failure. So that is to be elicited. And how do you evaluate and optimize this patient? Evaluate means you have to talk about the
Complete blood
investigation.
count, ESR,
Huh?
CRP, renal function test,
Hmm.
ECG, echo, and chest X-rays.
So always talk about the cardiac evaluation first, and then go for the other systems, because we have already given a clue that there is a patient with a probable rheumatic heart disease. So clinical examination for the severity of valvular disease by auscultating and finding out the severity of murmur, the opening snap, all these things will tell you about the severity. Then investigations, EKG to diagnose mitral stenosis or the presence of atrial fibrillation, which is one of the important complications. Echo to assess the valve size, pressure gradient, LA size, and thrombus. Then whether the treatment needed in the form of medical management or intervention like balloon valvuloplasty or even MVR, depending upon the severity of the valve problem. And of course, the regular other investigations that are required for a surgery. Anesthetic management.
Sir, should we include that ASO titer values and everything in the evaluation, sir?
Yeah, you can say the ASA grading depending upon the thing. Here, if you are examining a really live patient, then you have to give the ASA grading also. Under what grade you will assess, because that is what you do in your regular pre-operative assessment clinic, isn't it? You always give the ASA grading for all the patients.
Titer, sir. ASO titer, RF
ASO
factors.
titer. Okay,
Yes,
ASO titer is another thing to indicate whether there is any residual activity going on or not. Okay,
Okay. Yes,
so ASO titer will become normal once the patient is completely free from the disease process. So that is
Okay.
ASO titer is usually after the immediate sore throat that you will get that. When the active beta hemolytic streptococcus activity is very virulent at the time, you will get the ASO titer very high. But after gradually, when the rheumatic fever sets in, the ASO titer will gradually go down. But if it is still present, that means the activity is still quite severe. Active rheumatic activity is going on.
Yes, sir.
Okay, right. So what is the anesthetic management of this case?
Avoid
Sir,
decrease in cardiac output.
Again, goal, no, APCRRI. I mean PACRRI, preload, afterload, contractility, rate, rhythm, and ischemia. So what should be the preload?
Adequate preload, avoid hypotension.
Optimal or adequate preload. What should be the afterload? What do you mean by afterload?
Systemic vascular resistance.
Resistance. If the vascular resistance is too low and the vessels are dilated by your anesthetic technique, what will happen?
Decrease in the cardiac output.
Cardiac output.
Cardiac output will not be maintained and patient will have hypotension, isn't it? So your afterload also should be maintained. It should not cause any vasodilatation by your anesthetic technique. What about the contractility?
Avoid
Valve is
tachycardias.
you have, that is for rate. Avoid tachycardia is for rate. Contractility means you should say only three things: normal contractility, increased contractility, decreased contractility. So which one would you like to have?
Normal contractility.
Normal contractility, because the valve is already stenosed and left ventricular filling is reduced. So on this situation, if you have decrease the contractility, cardiac output will naturally go down. So you maintain contractility. Don't allow your anesthetic agents to decrease. Whereas in ischemic heart disease, to some extent, you can decrease the contractility because oxygen demand will be brought down. Okay, so this is how you analyze and say. And rate should be low, low, low. That is what Barash tells you. The textbook of Barash, if you read, mitral stenosis patients, you should have a heart rate which is low, low, low. It means the ideal will be between 60 to 70. Anything more than that is going to reduce the, what will happen if the heart rate is more in severe mitral stenosis?
Increase in the oxygen demand, also decrease in the blood supply to the.
Are you worried about oxygen demand in a 32-year-old woman?
Decrease
Poor
in the
diastolic filling.
Decrease in cardiac output.
Reduced filling of the left ventricle, which will lead to
Decrease in cardiac output.
Decreased myocardial
myocardial
decreased myocardial.
Myocardial infarction is not going to happen in a 32-year-old or a 20-year or a 25-year-old. The pulmonary vessels are quite good in that situation. Okay, nothing will happen to the myocardium. But the more important complication is you can precipitate a pulmonary edema because the left atrium is not emptying properly into the left ventricle. So the blood stays more in left atrium. So there is a back pressure on the pulmonary veins. And this pressure will be transmitted to the pulmonary capillary circulation. That will be transmitted to the pulmonary artery. And this will be precipitating an acute pulmonary edema. Okay, that is the risk in mitral stenosis, not myocardial infarction or ischemia. Okay, so that is much more, this will happen much more faster if there is a tachycardia than any ischemic event, right? So that is the answer that you are supposed to give in the examination. So rate should be low, and of course ischemia can be managed by adequate oxygenation and diastolic blood pressure. So as the surgical procedure is a minor one, it's important to assess the rheumatic heart disease severity and optimize the patient with the preoperative management. Then anesthesia can be even local infiltration. It's only a breast lump. So that can be managed with a LA with a local infiltration. Or you can think of any of the chest wall blocks. Nowadays what you use like PEC 1, PEC 2, SAB, TQBV, ESPB, all these blocks can be the sole technique instead of resorting to any GA or other things where you can cause all the changes in the PACRRI. These blocks also can be the ideal technique. Okay, and or GA with IV induction, LMA or ET intubation, maintenance with inhalation agents with spontaneous or controlled ventilation. All these are good choices for this procedure because this is a supposed to be minor surgical procedure. Third question again is a valvular heart disease problem. The case scenario is 76 years old male with complaints of right hip pain in the right hip after a fall while getting up from bed to found to have an ejection systolic murmur at the apex and second right intercostal space, and he is posted for fixation of fractured neck of femur. Analyze this case.
Elderly patient with valvular heart disease, probably aortic aortic stenosis for fracture neck of femur, sir.
Fractured neck of femur fixation. Okay. So elderly age group, geriatric age group, ejection systolic murmur in the aortic area, suggestive of aortic stenosis, fall and pain in the hip, suggestive of fractured neck of femur, which requires fixation. So these are the three problems in this case. And important points to be elicited in history.
Episodes of syncope.
Because aortic stenosis, is it a very evident diagnosis or a very subtle, slow onset problem?
Syncope is evident of aortic stenosis in elderly.
No, I'm asking about aortic stenosis, whether it is a very, very evident problem right from the start of the stenosis or it is a very late
Slow
presenting.
progressive disease.
Usually
progressive
asymptomatic.
disease.
Patients are very, very asymptomatic until they develop the very severe degree of stenosis. Okay. So what are the three important clinical features of aortic stenosis of a severe degree? Syncope, you have been telling one. And
dyspnea and exertion, sir. And angina.
Anginal pain, yeah. So the history again, because the geriatric age group, chronological versus biological, related changes in the system, and symptoms of ASD. Three important things: syncope, SAD. Remember the mnemonic SAD: syncope, anginal pain, and dyspnea. So if you have aortic stenosis, you will be very sad. So syncope, anginal pain, and dyspnea are the three important classical symptoms of aortic stenosis. So how is pre-op evaluation done?
Echocardiography and ECG, sir.
So much delay. Pre-op routine investigations for surgery plus test to assess the severity of AS, and need to plan whether the treatment can be conservative or you have to go for the current recommended treatment of TAVI or open AVR. Okay, so it depends on the severity of the aortic stenosis and the clinical symptoms of the patient. So if he is very dyspneic and valve is very much narrowed, then first you may have to correct this, or you have to take extra precautions in managing this case before you do the non-cardiac procedure. Okay, so how to plan anesthesia in this case? Supposing it is a moderate aortic stenosis. Again, what is the goal?
Normal.
PACRRI. Always, this is all heart diseases. Immediately think of PACRRI. What is the preload?
Adequate.
It should be adequate because all restrictive diseases never overload the patient because that cannot be pumped out of the heart. So that will cause an overload. Okay. Whereas regurgitant lesions, you can give a fluid more liberally. On the contrary, the stenotic lesions, whether it is myotic stenosis or mitral stenosis or tricuspid stenosis, If you overload the patient with preload, that cannot be pumped out. So that will all, where will it stay? It will stay only in the pulmonary circulation, and that will cause the precipitated pulmonary edema. So optimal, just enough to fill the ventricles. That should be the preload. Afterload, should it be reduced or preserved?
Preserved, sir. Avoid
Preserved,
decreasing.
very, very important. In aortic stenosis, the heart cannot pump more blood to fill up the dilated vessels. So unless you preserve the peripheral resistance, they will have sudden acute hypotension and very drastic changes in the cardiac function. Okay, so SVR, systemic vascular resistance maintenance, is very, 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 very important. Just as I told you about low heart rate in mitral stenosis, aortic stenosis, preservation of SVR is very, very important. Okay, so after load, preload, contractility should be maintained. Rate, always preserve the rate to a normal level, because too much of increase in the heart rate here will cause ischemia, because they will go for they already will have some hypertrophy because of the aortic stenosis. So any increase in heart rate will increase the demand, and it can precipitate a myocardial ischemia or infarction. Rhythm should be sinus rhythm, and all precautions to preserve the diastolic blood pressure to prevent ischemia should be taken care of. So, but the neck of femur fracture maintenance, fixation is a quasi-emergency. So surgery is required at the earliest. The options are based on the severity of AS and patient symptoms. So mild to moderate AS may be managed by GA with a nerve block for pain relief. Okay. Whereas central neuraxial blockade carries the risk of sudden hypotension, which the heart cannot compensate because of the fixed output state. Okay. So the examiners will try to lead you and make you commit. Normally you do fracture neck, and especially elderly patients, spinal is safer, isn't it? Why not you do it under spinal? That is the way the examiners may try to tempt you to commit and say, I will give a spinal. But it is a very, very risky thing to do it in a patient with aortic stenosis. Now the next scenario is a 9-month-old female child with a history of failure to thrive, repeated respiratory infection, cough, diagnosed to have a pansystolic murmur at the fourth right intercostal space from birth. Posted for the repair of cardiac defect itself. So analyze the case.
Pediatric patient with congenital heart disease posted
Cardiac
for
disease.
cardiac surgery.
Okay. So pediatric patient, congenital cardiac defect, probably a VSD. Closure of VSD means cardiopulmonary bypass surgery. It's an open heart procedure. So of course we can try the interventional procedures nowadays are available, but if it is a large defect, it will definitely require a open heart surgery. So it may have to go for cardiopulmonary bypass surgery. These are all the problems in this case. Points to be elicited in the history. Whenever you get a pediatric patient, what are all the history you should elicit?
About the feeding, sir.
Starting from
Antenatal and birth
antenatal
history. Okay,
birth
history of being
history,
patient with
development.
a birth history and babies, including mother's antenatal period, gestational age at which the child was born, and the mode of delivery. All these questions should be asked in all pediatric patients. Then developmental milestones, because now already the child is 9 months old, whether the milestones development was normal. Any other associated congenital anomalies? What are the other congenital anomalies normally a VSD child can have?
Cleft lip, cleft palate.
Cleft
Sir.
lip and very, very good. And growth and weight, whether it is appropriate for age, because the child had repeated respiratory infection and cough, nutrition may not be adequate. So measure the, whether see the weight of the child and see whether it is appropriate for the age of the child, and current status of cardiac and respiratory function. Okay. These are complications of due to VSD. What are the complications due to VSD that can happen?
Congestive heart failure, sir.
Congestive heart failure. Okay. Right heart failure, more specifically. Because there is a left to right shunt. In the VSD, there is a left to right shunt. So there is a overload on the right ventricle and the pulmonary circulation. Okay. So that produces a strain on the right ventricle, and that is the problem that you have to identify. And pre-op evaluation,
Same
any
ECG
cardiac
and
patient,
ECG.
EKG,
Echo.
in here also atrial fibrillation may be present. Conduction defects also may be there because of the discontinuity in the septal wall. There may be conduction defects. Echo to assess the size, shunt direction, and quantity of directed blood. Okay, so these are very common investigations that we have to do. Plan of anesthesia.
General
The cardiac
anesthesia.
defect repair. So it's an open heart procedure. So what is the plan of anesthesia?
General anesthesia with
General
endovascular
anesthesia.
intubation for with
Here with controlled
CABG.
ventilation, and the surgery is done under cardiopulmonary bypass. Okay. So post-op complications. This particular surgery. How is the repair done in VSD? Even though most of you would not have had a chance to witness unless you are working in a center where cardiac surgery is also performed routinely, where you had a posting, you should have some theory knowledge about these problems. So how can the VSD be repaired? What are the techniques?
Surgical
is-
patch closure.
First, if it is a small defect, you can do it primary closure itself. Pull the tissues and then close it primarily. Only large defects require a patch graft. It can be a pericardial patch or it can be a synthetic patch. Okay, so it depends on the particular type. So based on that, the complications are bleeding, infection, arrhythmias, or heart blocks. Okay, when they take a suture, which part of the conducting system of the heart runs through the ventricular septum?
Bundle of his.
Bundle of his, then goes down to right and left branches. So there may be a suture which may interfere with that bundle of his. So conduction blocks can happen, or because the valves are very close to the septum. The aortic valve is close and the pulmonary valve is also very close. So the surgeon may injure those valves also. So injury to the valves are also very common short-term complications. Long-term complications, there may be a residual VSD. Closure may not be complete, or you can produce valve problems, or already pulmonary hypertension could have developed because of the constant left to right flow, and right heart failure had already set in, or sometimes SA node dysfunction also can happen. Okay, these are all the problems in the post-op you have to anticipate. Now the next scenario is 1.5 years old female child with the delayed milestones, failure to thrive, bluish discoloration of nails, lips, and tongue, has episodes of fainting and hospitalization. What is the diagnosis? How to treat it?
Cyanotic heart disease.
Cyanotic heart disease. Okay. The possible diagnosis is tetralogy of Fallot. Okay. Treatment options are palliative shunt or total correction. Okay. So when do you resort to palliative shunt? When do you resort to total correction? What are the components of tetralogy of Fallot?
Right
Ventricular
ventricular
septal
outflow
defect.
tract obstruction, ventricular septal defect,
Overriding
overriding
of
of arch of aorta,
Aorta.
pulmonary stenosis.
pulmonary stenosis.
Pulmonary stenosis. Okay. The main culprit is pulmonary stenosis. Okay. And this pulmonary stenosis combined with the aortic ventricular septal defect and malposition of aorta and right ventricular hypertrophy is only a consequence of the pulmonary stenosis. Okay, so the basic primary defect is pulmonary stenosis. So you have to repair these three things. Pulmonary stenosis has to be dilated. It has to be made a normal valve, and the ventricular defect has to be closed. And once you close the ventricular defect, the overriding aorta may get corrected because you are pushing the aorta to face the left ventricle instead of the right ventricle. So, what type of cyanosis happens in this case?
Central cyanosis.
Central cyanosis. Because the deoxygenated and oxygenated blood get mixed in the heart itself. So it is called central cyanosis. What is the other type of cyanosis?
Peripheral cyanosis, differential cyanosis.
Differential cyanosis. Very good. How do you differentiate between peripheral cyanosis and central cyanosis?
Sir, central cyanosis does not get relieved, cured even after 100% oxygen.
100% oxygenation. Very good. Whereas peripheral cyanosis will be relieved by oxygenation, and is oxygenation alone enough to relieve the peripheral cyanosis?
Temperature.
The patient has to be rewarmed. Patient's temperature also, mainly hypothermia is one of the reasons for peripheral cyanosis. So patient should have normal body temperature, and oxygenation will relieve the peripheral cyanosis, which will not happen with. When will you get differential cyanosis? Patent foramen oval.
Patent
PDA,
ductus
sir.
PDA. PDA is a left to right shunt, which is just like a VSD only.
Yes, sir.
Aorta to pulmonary circulation.
Coarctation of aorta.
Coarctation of aorta, correct. We can get it in coarctation. What is Harlequin syndrome? We just saw that in a few classes ago, where also you get differential cyanosis.
It is a complication of ECMO where we choose
ECMO,
the peripheral.
that also produces differential cyanosis. Okay, right, that's hydrogenic rather. So, after the diagnosis, analyze this case. What are the problems in this case?
Pediatric patient.
Pediatric patient, very good. 1.5 years old female child. Second, congenital cyanotic heart disease. So all the complications of cyanotic heart disease, need for major vascular or open heart surgery. Okay. So what is the most important history to be elicited?
History of cyanotic
spells, sir.
Recurrent.
History of cyanotic spells. Any
Recurrent
complications?
infection, respiratory
Birth
infection.
history. Always pediatric. I told you first take the birth history. Is there any premature birth or NICU admission? Time of detection of the defect, whether at birth or later. Will all the cyanotic heart disease exhibit at birth itself, or will it take some time to exhibit?
It takes 3 to 4 weeks.
Why?
So that PDA problem starts after the PDA closure.
After PDA closure only, you will get it some. Okay, so most of the cyanotic heart disease will not be detected at birth, but it will be detected soon after the PDA closes, which may happen in 3 to 4 days, not 3 to 4 weeks, but 3 to 4 days later, you will see once the PDA closes, the shunting will happen. So instead of left to right, it will have a right to left shunt, and the patient will start exhibiting the cyanosis. Right. And look for any other congenital anomalies. And hypercyanotic spells. This is one common question. You have to be ready to answer this. What is this hypercyanotic spell, and what is the purpose of the child squatting? If the child is a grown-up child who can walk, immediately they adopt the position of squatting. What is the reason for that? What is the cause of these cyanotic spells?
Cause is mostly due to the infundibular spasm, sir, which does not allow the blood to get into the pulmonary valves.
Okay. So what happens?
Why it compresses the femoral vessels, raises the SVR, and so the venous return to the heart is good.
Shunting of blood decreases, sir.
Shunting of blood decreases. That is the correct answer. So it decreases the shunting. So the patient will exhibit acute increase in bluish discoloration and desaturation will happen. So this is the position that they adopt by increasing the resistance to increase the SVR. So always SVR should be higher to prevent the right to left shunt. So that left side pressures will prevent the shunting from the right side. So if you see a child with cyanotic spell, how do you treat it?
Beta blockers to relieve infundibular spasms.
First oxygen,
Okay.
sir.
100% oxygen, sir.
Oxygen.
Okay.
We can give alpha
The
blockers and
list is given in all the books.
Easiest
Whenever
position.
you read about cyanotic spells, there are 4-5 steps that you have to follow. First is 100% oxygen, whether it's going to be helpful or not, at least to increase the oxygen supply to the brain. You give 100% oxygen. The examiner may ask you, this is central cyanosis, what are you going to achieve by giving 100% oxygen? But it will help in improving the oxygenation to some extent. From say 45%, it may come to 55 or 60. That will definitely help the brain tissue to have more oxygen compared to the lower saturation levels. That is the reason for giving that, not for the idea of completely correcting the desaturation, number one. Number two, you give IV fluids to improve the venous return to the heart, because you are going to preload should be adequate. Then you give morphine, which will dilate the pulmonary vessels and improve the flow through them. And phenylephrine you can give to improve the systemic vascular resistance. And beta blockers to relieve the infundibular spasm. So drug therapy is morphine, phenylephrine, and beta blocker. Other supportive measures are oxygenation and IV fluids. These 5 points you have to say in the examination. Okay, that is the treatment of cyanotic spells. Milestones and growth, of course, we have to ask. Any neurological complications? Why you should ask about neurological complications?
Coexisting Vactral anomaly.
Vactral anomaly.
Brain abscess is more common with
Brain abscess or seizure activity. Because of chronic hypoxia, patient may have seizure activity also. So these two are the common neurological complications which may be present, and infections in the brain, especially abscess. What physical examination findings you will be able to elicit in these patients? General appearance and systemic examination of the heart. What are the findings you have to look for?
Sir,
Cyanosis on general examination, we can see, sir. Central cyanosis.
Okay.
built of
So where all you look for central cyanosis? Which are all the
Lips,
sites in the body? Lip.
lips, mucous
Lip can
membrane.
have a cyanosis even in peripheral cyanosis. When the patient is shivering and having a cold. All of you would have experienced when you go to a high altitude and the temperature is very low, your lips might become blue. Which is the ideal site to locate central cyanosis?
lips, tongue, and
Palate. Palate
Sir?
is the palate and conjunctiva. Okay, these are the two locations where you elicit the central cyanosis. Lip can, as I told you, lip can become cyanosed even in cold weather. Okay, so the ideal locations to detect central cyanosis is the palate and the conjunctiva. Right. Then what else you will see apart from cyanosis? What will happen? There is a chronic hypoxia to the digits.
Shunted growth, clubbing.
Clubbing. That is a very important finding. Will they have clubbing or not?
Yes, sir.
What is the cause of clubbing? Once you say clubbing, lot of questions can be asked about clubbing. What is definition of clubbing?
Abolition of
Bulbous
nails.
enlargement.
Bulbous enlargement of the tip of the digits, whether in the foot or in the hand. Okay, but what happens exactly in clubbing?
so chronic hypoxia leading to proliferation of
Okay, that is the pathophysiology you are describing. chronic hypoxia leading to increased capillary blood flow, increased nutrition, increased tissue proliferation. But what exactly happens? How do you identify that?
Angle, loss of
Wanda.
angle.
Levy-Bond hand
Levy-Bond
angle.
angle.
What is Levy-Bond hand angle? What is the
Angle formed
normal angle
between
and
nail
outlet?
plate
45
and
degrees.
It is the obliteration of the angle between
Angle
the
between
nail and the
nail
nail
bed.
bed. That is the definition. Okay, it is the obliteration. Normally, it is about 160 degrees, but in uh, clubbing, it will become 180. It will become bulbous, so it will become 180 degrees. It rather go up like a pillock and not have a bend in the middle. What is Shamrock's window? It is again another test to find out the presence of clubbing in mild degrees of clubbing.
a diamond shaped formed by like approximating the two nails.
Tips, the distal phalanx. Okay, the distal phalanx of index finger, if you approximate like this, you can see a diamond shaped gap between the two nails, which will be obliterated if you have a clubbing. That's called Shamrock's window. Okay? So these two findings, obliteration of Levy-Bond angle and Shamrock's window absence, are the two important clinical examinations which may be asked. And of course, there are a lot of theories to contribute. What are the most accepted theories for that? One is hypoxia producing increase in the capillary density, increased blood flow, increased nutrition, increased proliferation of tissues, plus any other factors which increase
Platelet
platelet-derived growth factor and vascular endothelial derived growth factors also increase, and these are supposed to be the theories for the presence of clubbing. Okay. So examination, growth and nutrition, stenosis location and severity, clubbing, grade of clubbing also they can ask you, the causes and mechanism of formation, serious presence of murmur. What murmur you can get?
Low murmur, sir.
What
Ejection
murmur?
systolic.
Main problem is pulmonary stenosis. So
Ejection
you will get
systolic.
an ejection systolic murmur of the pulmonary stenosis. Okay. Right. What investigations are needed?
complete blood count with the coagulation and coagulation values.
Hemoglobin and hematocrit, because they will have severe polycythemia as a compensatory phenomena. Then coagulation screening for platelets and fibrinogen level. CXR to see the oligomeric lung and boot-shaped heart. EKG, changes in QRS axis, right ventricular hypertrophy, echo to see the size of the VSD, pulmonary valve size and blood flow in PA, cardiac catheterization in addition to routine pulmonary blood flow. Can also see the coronary anatomy. Why coronary anatomy is important in these cases? They have aberrant coronary vessels, okay, because this congenital anomaly is associated sometimes with aberrant coronary anatomy vessels, and if this is not identified before correction, the patient may land up with an acute coronary ischemia. And you must see the atriopulmonary collection, native PA, number of lung segments receiving blood supply from the pulmonary artery or from the aorta, which is called the dual supply. And why ABG is not needed in these cases?
Anyway, their baseline saturation will be around 85 to 90 only.
95. So there is no point in seeing the saturation. Okay. And what is the management between pre-intro and post-out? How is this correction done? Is it by open heart surgery, cardiopulmonary bypass, or is it by beating heart? It is done by
Open heart.
open heart surgery. Okay, so pre-op adequate hydration Sometimes when the hematocrit and HB are very high, these children may have a hemoglobin of 18 to 20. So if that blood is so thick and viscous, you have to do what is called preoperative dilution. Hemodilution has to be done by reducing that so that the peripheral capillary flow will be good, and avoid IM injections as crying may precipitate a cyanotic spell. Check availability of platelet and fibrinogen. Crystalloid priming. Instead of normally we do only blood priming for children when they undergo cardiopulmonary bypass. But here, because there is a compensatory polycythemia, the difference is they may require only a crystalloid priming if the hemoglobin is more than 20 grams per deciliter. Intraoperative anesthesia induction can be with ketamine. Why you prefer ketamine?
It increase sympathy.
It
Decrease.
maintains
Raise the
resistance,
Maintain the
vascular
SVR.
resistance.
Okay, you don't want any fall in the SVR, which will aggravate the right to left hand. So to maintain the SVR, your preferred agent is ketamine. And challenges of cardiopulmonary bypass in the infant or pediatric age group. Coronary anatomy to prevent any injury to the right coronary vessels, as I said earlier. And goals during anesthesia are to preserve the SVR and reduce the right to left hand further. And these are the important goals. Post-op, defective surgical repair can result in failure of surgery. And again, you can have a conduction block because there is a VSD which requires repair. And coagulation may be already affected in these children, and they may have bleeding, and you may have difficulty in weaning from the cardiopulmonary bypass because especially if the right heart is already very much affected. So what are all the other things you have to learn with regard to this particular cases? Classification of congenital heart diseases. So how do you classify the congenital heart diseases? Cyanotic and acyanotic. That is one classification. Any other classification? Especially among the cyanotic, duct dependent and duct independent heart diseases. Okay. Then the components of TOF, which we said. What is pentology of fellow? Instead of tetralogy, if you have a pentology.
With ASD, sir, talk with ASD.
ASD also included. So along with PSD, you will have an ASD also. Then it is called the pentology. And pathophysiology of hyperspinotic swells. Treatment of swells. What is a pink tet?
The mild form of TOF, sir. Here there will be
Tetralogy
minimal.
patient who is not showing any evidence of cyanosis, but all the features of pulmonary stenosis is there, some amount of VSD is there, overriding may not be very severe, hypertrophy, hypertrophy may not be very severe because there is a pulmonary flow coming from any other collaterals like patent ductus or a communication between the aorta and the pulmonary vessels may be present, which will supply. But if you do an echo, you will find all the defects that you describe in the tetralogy will be present. And that patient is called the pink tet, who may not have that much of desaturation, and they do very well, and they live up to adulthood and do normal work, everything without any problem. Okay? So that is one variant of tetralogy of Fallot. Then CNS complications. This cerebral abscess, they may ask you, how will you, supposing this abscess is very large and causes a rise in intracranial pressure, and patient has an uncorrected tetralogy of Fallot still present. A 6-year-old child develops cerebral abscess, ICP raises, child becomes disoriented, sensorium is altered, there is a nausea and vomiting because of the raised ICP. It requires a drainage of this abscess. How will you give anesthesia? That is a very common question or scenario they may ask you if you get a case of tetralogy in the exam. So what is the challenge in that case? Patient has cerebral abscess with raised ICP. That is one problem. The other problem is an uncorrected tetralogy of Fallot with a right to left shunt. So how to manage these two? Under what anesthesia you should do this surgery? Can it be done under local? A 6-year-old
General
child or
General
anesthesia
anesthesia.
you
with the
require
scalp
general
lock.
anesthesia. So the main aim of the examiner is to find out whether you are thinking logically to balance the two situations. One is you should not allow the ICP to rise further by your anesthetic technique. At the same time, you should preserve the whatever cardiac function is there without further desaturating the child. So, what are all the drugs that can be safely used to give GA? Okay, think of it and tell me later. Okay, and palliative procedures. What are the palliative procedures that are done? The first beginning itself, I asked you, it can be palliative or a corrective procedure. So, what do you mean by palliative procedures?
They can temporarily divert the flow and
improve the pulmonary blood flow. Here the basic pathology is because of the severe pulmonary stenosis, blood from the right heart or right ventricle is not going into the pulmonary circulation. So from extracardiac communications, you create a conduit between the systemic vessel like subclavian or the brachiocephalic and you connect it to the pulmonary artery which is going to the lung directly so that extra flow will be there. Or already a nature has got given a communication between the aorta and the pulmonary artery that can be reopened or that can again be communication can be established using a synthetic graft. So any communication between the systemic vessels and the pulmonary vessel to improve the pulmonary blood flow is called a palliative procedure. And the common palliative procedure that is done is
Modified BT shunt.
modified Blalock section. Okay, don't use the acronyms in the examination. Always tell the full name. So, modified Blalock section is the procedure that is done just to improve the pulmonary circulation or pulmonary blood flow. Okay, that will be done if the patient is born with a very severe right heart failure, so that you will salvage the patient to some amount with where they can allow the child to grow, getting some nutrition, and then withstand the major open heart procedure until the time to salvage the palliative procedures are done. Okay, that is the indication for that. And anesthesia for them is more challenging. And the common question they will ask you is, supposing you anesthetize a child for Blalock dissection, and the starting saturation is 78 or 70%, let us say. Once a surgeon has completed the anastomosis between the systemic vessel and the pulmonary vessel, what should be the saturation?
40 to 60 is a postductal.
40 to
ideally
50.
we can maintain what we had in a pre-op session.
So you don't have to get any increase in the value. Is that what you mean?
Increase can increase the pulmonary.
No, I will give you a
blood
scenario. You have a starting saturation of 70. Surgeon completes the surgical procedure. Saturation is 85 in a child. Another child saturation is 98. Which one you will accept?
85.
85 I can
85,
accept, sir.
because 98 means it is too much of blood flow. Then there will be no flow in the system circulation, and the pulmonary vessels will not be able to stand that load. That will land up in an acute pulmonary edema. So too much of correction is also not correct. So you have to get a marginal raise so that the things can be corrected at a later stage with a complete correction. Okay, this is one catch question they may ask you regarding Blalock section. And can TO patients grow to adulthood? Yes, of course. If there is a mild shunting, they can definitely go. And there are reports where girls with TOF have grown up to adulthood, got married, got children, and come for delivery with a existing tetralogy of Fallot also. There are a lot of cases reported. And incidental surgery in adult TOF, what is the anesthetic management? Is it easy or it is difficult? If a person has grown up to adulthood with the TOF, what are the precautions we have to take?
They have grown
The main
into
goal is
adult
prevent
form, so
further right to left turn should be avoided. Okay, there will be some amount of right to left turn. Make sure that it doesn't get aggravated and too much of right to left turn. So maintain SVR all the time. You will be safe. So giving a central neuraxial have block for a hernia in a patient with POF, definitely you will aggravate the right to left turn because the SVR will fall. So in that cases, a guided epidural or a combined spinal epidural with RGA, these are the techniques which will be much more safer. So the main goal in managing a adult patient with POF is to maintain SVR, maintain SVR, maintain HVR. That is the Taraka mantra. Okay, right. 65 years old male, chronic smoker, 2 pack years for 45 years, history of cough with expectoration, admitted to ICU in last 3 years, has multiple 3 times in last 3 years, has multiple symptomatic gallstones posted for lap cholecystectomy. Analyze the case.
Elderly
Elderly
patient,
chronic
chronic
smoker,
Geriatric patient, 65 years old, geriatric patient. Okay. Then
It's active infection, cough with expectorations.
number of second point is chronic smoker.
chronic
Number of
smoker
pack
with
years. So 2 pack per years means what is the number of pack years?
90s.
90, yeah, 2 into 45, 90 pack years with history of cough with expectoration with admitted 3 times in last 3 years. What is the diagnosis?
Chronic obstructive pulmonary.
Exacerbation of
COPD. What type of COPD? What are the 2 types of COPD?
chronic bronchitis and
Chronic
emphysema.
bronchitis. Another is emphysema. Okay, so you must be specific which type of COPD. Okay, the patients with chronic bronchitis only have the classical history of getting admitted 3 times in the last 3 years. Every year once they will get admitted. That is the classical history in chronic bronchitis. So 65-year-old geriatric age group, 90 pack years of smoking, history of admission to ICU 3 times, suggestive of chronic bronchitis. And this patient is posted for
lap
lap cholecystectomy, which is going to use for carboperitoneum CO2. Okay,
Yes,
so that
CO2.
is another problem. So all the 4 problems have to be analyzed. Important history.
About cough with expectoration, then history of breathlessness.
Sir, any exacerbation, effort tolerance, medications the patient is on,
Evening rise in temperature.
and effort tolerance.
Okay. Again, the first point always is because it's a geriatric age group, chronological versus biological age, smoking related complications. Because the second point is number of pack years is 90. So smoking related complications. Third is duration of COPD. Not all smokers will develop COPD. Some of them may be happily smoking till their life without any problem. So duration of COPD, effort tolerance, treatment taken, then gallstone related problem like pain, abdomen, jaundice, nausea, vomiting, etc. These are the important history to be elicited. Physical examination. If supposing your diagnosis of chronic bronchitis is right, what will be the appearance of the patient?
I look for clubbing.
I'm asking a specific question and you are saying look for clubbing.
thin emaciated.
Patient will be emaciated in chronic bronchitis. Blue bloaters and pink puffers. That is the description, isn't it? For chronic bronchitis patient, blue bloaters, obese, high-nosed, bluish patient. They are chronic bronchitis patients. Thin puffing patients are emphysematous patients. So examination will show a blue bloater, nicotine staining of the fingertips. Systemic examination, you have to do a systemic examination of the RS, CVS, abdomen, look for any lung signs, etc. Pre-op evaluation and optimization.
So
Cessation of
smoking
smoking can be advised.
Cessation of smoking, first and foremost, very good. Then
to control exacerbation and to continue the medications to improve
right,
effort.
what medication? Optimization means you must be very specific about what are all the medications you will give.
Sir,
Bronchodilators.
bronchodilators,
Bronchodilator.
inhalational
And-
steroids, antibiotics, and we have to improve the effort tolerance by preoperative chest physiotherapy and incentive spirometry.
Routine pre-op investigation, PFT if needed, 6-minute walk test, ABG, risk stratification using GOLD criteria or BORD criteria. What is GOLD criteria?
Sir, BMI, B is for BMI, obstruction, dyspnea, and exacerbation.
This
Effort
is
tolerance.
GOLD.
Gold criteria is a grading of COPD with the help of FEV and
FEV1 and FEC. Okay, so that's
FEV1 and
grading.
FEC.
Okay. So both of them can be used to assess the severity, and then pre-operative optimization, smoking cessation, incentive spirometry, chest physiotherapy, antibiotic cover, sputum reduction, bronchodilators. Okay, so these are all the things that are intra anesthetic management or lap cholecystectomy in this patient.
So plan is general anesthesia with endotracheal intubation.
Intubation, very good.
Effective pre-oxygenation, induction of choice is propofol, and we can
avoid
avoid stress responses with the help of lignocaine.
Will it be an irritable airway or a non-irritable
hyperreactive airway.
Hyperreactive airway. So important GA TTQ, or you can use second or third generation supraclavic airway devices also, plus RA, either TEA. What is TEA? Thoracic epidural anesthesia. Okay, and tab block, rectus sheath block, local site infiltration, intraperitoneal instillation. All this is the plan. So segmental spinal or epidural or transverse process with the block, erector spinae plane block in high risk patient. All these things also have been tried in very severe cases of COPD. What are the safe drugs to use in this case?
IV induction propofol better than thiopental, sir. Yes.
What about ketamine?
Ketamine also bronchodilator.
Bronchodilation.
It increases the airway secretions.
So can control it by glycopyrrolate. Okay. So induction can be propofol, etomidate, or ketamine. Then
muscle relaxant, avoid atracurium.
So you can choose between these three. What about analgesics and inhalation agents? So analgesics can be paracetamol, fentanyl, tramadol, dexmedetomidine, and lignocaine, ketamine, and magnesium sulfate. All these are safe anesthetic analgesic drugs. Inhalation, CO, iso, halothane also is a very good bronchodilator, but not used commonly nowadays. And it is nowadays not preferred also despite the good bronchodilator property. Why?
Arrhythmogenic.
It is more arrhythmogenic, especially in the lap procedure where carbon dioxide is used. And already COPD patients may have a persistent hypercapnia that may produce a cardiac arrhythmia. So that is the reason why halothane is not preferred drug. And reversal neostigmine with atropine in a titrated dose, or sugammadex for correcting the reversing the rocker. How to manage an intra-op tight bag? This is a very common question that will be asked.
Sir, 100% oxygen, positive pressure ventilation, then
Back is already tight. You have intubated.
Deepen the
you-
anesthesia.
Deepen the plane of
Plane of
anesthesia.
anesthesia by giving proper.
All not read the earlier topics.
So, first change
Identify
this.
whether the tight bag is due to the machine cause or the patient cause. This is the first answer expected. Please don't immediately jump to saying that I will do that, I will do this. This is the first answer that you have to give. Because sometimes, the machine may be the faulty thing to cause a tight bag. Okay? So the machine causes are high flow of gases, inactivated oxygen flush, which you have used during induction. You have forgotten to switch it off. Stuck valves, thin tubes, obstruction in ET tube or endobronchial intubation. So these are all the mechanical or machine causes. Patient causes bronchospasm. That is managed by salbutamol, aminophylline, magnesium sulfate, epinephrine, chlorpheniramine maleate, hydrocortisone, euphoratorium, and ketamine. So the mnemonic that I have given in my earlier presentation on COPD is SAME, same chick, CHIK. Okay, so all the 8 drugs, that will be the mnemonic to remember. And fluid overload or cardiac failure is another cardiac causes for the right back also. So these are all the common things that you have to remember. So 45 years old female patient with a history of yellow discoloration of the eyes with severe itching and clay colored stools, abdominal pain in the right upper quadrant of the abdomen, found to have a stone in common bile duct, posted for removal of the stone. So this is the scenario I told in the beginning. Needs to be have a clear concept to give a correct answer in the examination. So analyze the case.
Sir, history is suggestive of cholestate obstructive.
Obstructive jaundice because of the gallstone. Very good. Signs and symptoms suggestive of obstructive jaundice due to GBT, gallbladder stone. Okay. Then patient may require stone retrieval by endoscopy or open surgery. Okay, that is the procedure that has to be done. So, what is the definition of obstructive jaundice? The question may start like this in the examination. How do you define obstructive jaundice?
Sir, increase in the level of direct conjugated bilirubin in the blood.
That is the, after the investigation only you can define whether it is obstructive or not. The failure of normal amount of bile to reach the intestine due to mechanical obstruction of the extrahepatic biliary tree or within porta hepatis. Okay, that is the definition. So bile is not able to reach the duodenum, and that is getting reflects back into the circulation. Okay, so we don't talk about the values of conjugated or unconjugated bilirubin. It is a failure of normal amount of bile to reach the intestine due to mechanical obstruction of the extrahepatic biliary tree or within the intrahepatic porta hepatis. At what levels of bilirubin yellow discoloration is seen in the sclera and skin, and why these structures are affected?
More than 5 grams
2
per
to
deciliter.
3. 2 to 3.
2 to 3, 5. Which one is giving their value? Why these structures are commonly affected? Why you see the low discoloration mainly in the sclera and skin?
They have increased elastic.
Elastin, yes. So sclera you will get it at 3 milligrams, and skin and mucous membrane you will get it at 6 milligrams. Double the amount is required to clean the skin and mucous membrane. Okay. And that is because bilirubin has high affinity for elastin, which is present abundantly in the sclera. Okay. What is occult jaundice?
Sir, it is identified only with the help of blood test, not clinically identifiable.
What is the normal value, and up to what value you will not see the jaundice?
1.2 to 2 milligrams per deciliter.
0.8 to 1.2 is the normal value, but up
Yes,
to
sir.
2 milligrams per deciliter of blood, you will not see the jaundice clinically. So normal bilirubin is 0.8 to 1.2 milligram, but up to 2 milligram, there won't be any yellow discoloration, and this is called occult or hidden jaundice. Okay. What is Charcot's triad?
Sir, intermittent fever, intermittent jaundice, and
jaundice.
pains.
Pain, yes. Okay. So there are symptoms of cholangitis, and the triad consists of fever, pain in the upper right quadrant of the abdomen, and jaundice. Okay. That is because of the inflammation in the biliary tree, which is called cholangitis. Describe the metabolism of bilirubin. So if you get an obstructive jaundice case, you will definitely be asked about how bilirubin is formed and how it is circulated, what is the final excretion, how it happens. This is a very common question that we have to be ready to answer.
So it is the breakdown product of heme, sir.
Heme, okay. Which is released from
the reticuloendothelial. So,
it is the site, but heme is released from where?
RBCs.
Effete RBCs. They are called effete or old RBCs, which have finished their lifespan. 120 days of life is over for the RBCs. So the name for such RBCs is called effete, EFFETE. Effete means old or senile RBCs. So these 120 days old RBCs which have finished their lifespan, they are broken down in the reticuloendothelial system, especially spleen, and from that the hemoglobin is released, and the heme moiety and the globin moiety are first cleaved or separated, and from this heme it is by further cleaving it is broken down and brought out to bilirubin. What type of bilirubin is produced there?
Unconjugated bilirubin.
Unconjugated bilirubin. What do you understand by the term unconjugated bilirubin?
So bilirubin gets conjugated in the
It
liver.
is not soluble in water, or it cannot dissolve in plasma. So how is it brought to the liver?
By albumin, sir, binding
By
with albumin.
combining with albumin. Albumin is a carrier protein. Okay, it will carry the bilirubin and bring it to the liver. What will happen in the liver to this bilirubin?
It gets conjugated with glucuronide
It gets
transferase.
conjugated and made water soluble. Okay, and then what happens once it is conjugated and becomes bilirubin glucuronide, which is a dissolvable form? Where will it go?
So via the hepatic duct, it goes to the.
What is the carrier for this bilirubin?
Duodenum, sir.
Bile. It is
Bile.
released in the bile. It's a part of the bile, composition of bile. Then it comes to the duodenum. And once it comes to the duodenum, what happens? How many percent will be reabsorbed? How many percent will be excreted?
So 70% is 70 to 80% is reabsorbed with the help of enterohepatic circulation.
What happens to the rest?
The rest is breakdown by the gut bacteria and excreted in the
urine.
In the stools as stercobilin and
Part
in
of
urine
it
as
is absorbed into the systemic circulation, goes to the kidney, and then eliminated via the urine. And that is the reason for the straw colored urine you have normally because of the urobilinogen converted to urobilin. Okay. Whereas the part that goes along with the feces, which gives again the brownish color to the feces, is this stercobilin. Stercobilinogen converted to stercobilin. Then this is the final end of that. Okay, so reticular endothelial system, old RBCs are broken down, heme is separated, unconjugated bilirubin along with albumin is brought to the liver, and again here it is glucuronized or made water soluble, and from there it goes into the intestines, and then part of it again 90% is reabsorbed and brought back to the liver, whereas the 10% goes out partly in the stools, partly in the urine. Okay, that simple is the metabolism of the urine. Describe the bile formation and what is the function of the bile. How is bile produced?
So bile is produced in the liver.
Liver means a whole liver. Histologically, you must say which particular cells are responsible for secreting the bile.
Hepatocytes.
Hepatocytes. Is it only hepatocytes which is contributing to the formation of bile? Hepatocytes in the liver produce bile by secreting bile salts, cholesterol, phospholipids, and other components. Number one. Bile secretion is stimulated by which hormone? Secretin is the hormone which stimulates. Then bile is concentrated in the gallbladder by reabsorbing water, electrolytes, and bile salts. And when food is eaten, the hormone cholecystokinin is released into the bloodstream. This cholecystokinin stimulates the gallbladder to contract and release bile into the small intestine. Here, even though majority is produced by the hepatocytes, some amount is also secreted by the cells of the biliary tree, which is called the cholangial duct. Okay, that also contributes.
Yes,
and
sir.
the total flow of bile per day is about 600 ml, of which 70% is derived from hepatocytes and 25% from cholangiocytes. Okay? And the main function of the bile is to facilitate lipid absorption, digestion, and to eliminate waste products from the body. Okay, this is the main function. How to differentiate between intrahepatic, post-hepatic jaundice? What are all the lab tests you have to do to find out or distinguish between a pre-hepatic, hepatic, and post-hepatic jaundice?
So pre-hepatic jaundice, the most common cause is hemolysis. So we can do CBC, lactate levels, and direct and indirect bilirubin values. So indirect bilirubin will be elevated in pre-hepatic jaundice.
It is unconjugated bilirubin.
Unconjugated bilirubin. In post-hepatic jaundice, conjugated bilirubin will be elevated.
Elevated. Intrahepatic, it will be both a combination of both conjugated and unconjugated. Okay. What other changes will happen? Any enzyme changes will happen in these conditions?
LDH, sir.
LDH in which condition? Pre-hepatic or
Hemolytic.
It's increased in pre-hepatic jaundice.
increased in pre-hepatic. Post-hepatic, which is the enzyme which will be elevated?
Alkaline phosphatase, sir.
Alkaline phosphatase, very good. So this is the formula that you have to remember. With regard to bilirubin, you will get more unconjugated in pre-hepatic, where as I told you, it gets broken down at the reticular endothelial system. Both unconjugated and conjugated will be elevated in hepatic, and mostly it will be conjugated in post-hepatic because it is getting water soluble and coming out in the bile. It will be mostly conjugated. And urine urobilinogen will be very high in pre-hepatic, so you get a very dark colored urine, whereas hepatic you will have less of urobilinogen, and post-hepatic you will have a probably because there is no thing coming out, you will have a lesser urobilinogen. But bilirubin level will be very high in post-hepatic, and it will not be present in pre-hepatic. And stercobilin will be very high in pre-hepatic, whereas it will not be present, so you get a clay-colored stool. And alkaline phosphatase will be enormously raised. What about prothrombin time? What will be the prothrombin time value in these three conditions? Will it get
So
affected
it
in
is
all the three, or it will get affected only in one particular
only in the
condition?
hepatic condition it increases.
Hepatic and post-hepatic prothrombin time will be altered, prolonged. Whereas in pre-hepatic it will be normal. It is another way to distinguish between pre-hepatic and hepatic. Right? What is the cause of pruritus in obstructive jaundice?
Bile salt, sir. Sodium
Bile salt.
toxic.
What do they do? Only bile salts? No other transmitter or compound which is responsible for that. There are a lot of theories. It is not a single cause which is affected. Bile salts, especially the phenodeoxycholate and deoxycholate, stimulate the release of histamine from mast cells, and plasma histamine concentrations are increased in pruritic patients. That is number one theory. The second theory is serotonin may be important in the central nervous system to niche perception and sensory modification, which may also be a direct mediator of pruritus in these patients. Second cause. Third is steroid hormones may modulate neuronal excitability in cholestatic patients since they act as a number of important neural receptors involved in the itch pathway, including TRP1, GABA, glycine, glutamate, and serotonin receptors. So that is also implicated. The fourth is endogenous opioids like proencaphalin and metencaphalin are involved in the mediation of pruritus. And lysophosphoric acid, LPA, is a form of from this choline, phosphatidylcholine by the enzyme autotoxin is a signaling molecule that acts on a number of specific G protein coupled receptors present in neuronal cell membranes. So all these 6, 1, 2, 3, 4, 5 mediators are all implicated in the cause of the pruritus, and that is the reason why sometimes the examiners ask you what is the treatment for that. They have tried so many things. They have tried antihistamine, they have tried ondansetron because it is involving steroid, and they have given naloxone because it involves opioids. So all these things, various drugs and pharmacological treatments have been tried. Okay. So how is pruritus treated? It's by opioid antagonists, polystramine, rifampicin, phenobarbital, oral dihydroxytryptamine antagonist, and urodeoxycholic acid inhibitors, propofol, lidocaine, charcoal, hemofiltration, plasmapheresis, and sometimes in the severe advanced stages, liver transplantation only has helped in the curing of the itching. So that amount of struggle has been taken. What other complication can be detected from the starch marks due to pruritus? Supposing patient has got severe pruritus, which is usually the initial stages. In advanced stages, it gradually goes down, but initial stages, patient may have severe itching. And if you find what one information about the other pathology that you can detect from the scratch marks?
hepatic encephalopathy can be ruled out.
So coagulation defect. So bleeding from the scratch mark indicates coagulation abnormality. Okay, those patients will usually have a prolonged prothrombin time. So in those patients, the scratch marks have blood bleeding tendency, and you see clotted blood appearing there. Describe the changes that happen due to the obstruction within the liver. What will happen? Supposing the bile is not going to flow forward into the intestine, second part of the duodenum. What will happen? Either due to say the gallstone or a malignancy or any other reason.
Intrahepatic
So
biliary dilatation.
what is the normal bile secretory pressure? So it is about 15 to 25 centimeters of water. When this increases to 35 centimeter, bile flow is suppressed. This high pressure leads to cholangiovenous and cholangiolymphatic reflux of bile. This causes intrahepatic biliary radicular dilatation. This dilatation does not happen in hepatic fibrosis or cirrhosis. So in advanced case, that is why many of the cirrhosis patients, they do not develop jaundice because this reflex dilatation cannot happen in them. The next thing is increased biliary pressure leads to disruption of the tight junctions between hepatocytes and bile duct cells with increased permeability, and the bile starts seeping into the sinusoids that mixes with the blood. This stimulates neutrophil infiltration, increases the fibrinogenesis and deposition of reticulin in portal triad, and the reticulin fibers get converted later on to type 1 collagen, and this can lead to fibrosis that obstructs blood flow and increase the portal pressures. So ultimately portal hypertension will happen. So this is why long-standing diabetes, jaundice, initially may not have portal hypertension, but if it is not treated in time, then it will ultimately lead to portal hypertension because of the stimulation of the reticulin fibers, which will get converted to collagen, leading to fibrosis. So it is not only the alcohol abuse which can result in fibrosis and cirrhosis, it is also long-standing diabetes, especially see a pancreas patient. If you don't treat them in time, before you remove the pancreas and cure the cancer, patient can die of liver failure also. So what changes occur in liver blood flow secondary to obstruction of the bile flow? One clue is the obstruction and the increase in the bile pressure can be acute or chronic. As acute will happen in CBD, that is CBD stones, common bile stones will produce an acute rise in the bile flow pressure. Whereas a pancreas, head of the pancreas will cause a chronic increase in the bile pressure. So what will be the change in the blood flow? What is the peculiarity of blood flow to the liver?
Dual blood supply, sir.
It has a dual blood supply. One is by
Portal vein.
Portal.
hepatic artery, the other is by portal vein. Okay, what is the purpose of hepatic arterial flow?
Is a power
Mainly for oxygenation. Mainly for, it is a more oxygenated blood. Okay, that is the real arterial blood. So it is mainly for oxygenation, whereas portal venous blood flow is mainly to carry the nutrients for metabolism. And so this dual supply, how will it be affected if it is an acute pressure? How will it be affected if it is a chronic obstruction? The acute rise in pressure increases the hepatic arterial blood flow for a compensation. Okay, whereas there will be no change in the portal blood flow. Whereas in chronic rise in pressure, it will be a total decrease. Both hepatic as well as portal flow will decrease, and dilatation of sinusoids will happen, and portal hypertension will develop. So in acute changes like CBD, you will not get portal hypertension. Whereas in chronic cases like cirrhosis, the CA pancreas or other extraneous condition, which gradually increase the pressure, that will cause this particular problem. What effects on the renal system can happen in the obstructive jaundice patient? What happens in cirrhosis liver? What is the effect in cirrhosis which happens in the renal effect of cirrhosis?
Hepatorenal syndrome.
Hepatorenal syndrome. So same renal vasoconstriction can happen in obstructive jaundice also, which will reduce the cortical blood flow, and there will be activation of complement system, which will cause fibrin deposition in the glomeruli and peritubular sites, and cortical necrosis can happen. Okay, so these are the pathology that can happen in obstructive jaundice, and these changes decrease the maybe due to decrease in cardiac function as well as increase in atrial natriuretic peptide levels leading to hypovolemia, and also endotoxemia can affect the renal function. So the pathology is slightly different from cirrhosis because endotoxemia also plays a role here, whereas in hepatorenal syndrome, it is mainly the afferent glomerular vasoconstriction, which causes the decreased cortical blood flow and the filtration. How is immune system affected and what is the complication due to this? Can patients with jaundice become immune compromised? Yes, immune function suppressed due to impaired T cell proliferation, decrease in neutrophil chemotaxis, defective bacterial phagocytosis, and decreased function of the Kupffer cells within the sinusoids. Okay, all these things lead to immune function. So, what is the complication that can happen because of the reduced immunity?
Sepsis, sir. Spontaneous.
Spontaneous bacterial
Arterial
peritonitis.
peritonitis.
Yes, very good. The reason for the development of spontaneous bacterial peritonitis is because of the decreased immune response. What happens to coagulation in obstructive jaundice? Already I told you how to distinguish between the
All procoagulant coagulants.
prothrombin time, which is why prothrombin time is a very important thing in jaundice or in any liver disease patient. What is it in the important marker of?
It is acute chronic markers.
It
Acute
helps
marker.
in the assessing the severity of the disease. Okay, when prolonged prothrombin time indicates a very severely affected function. So it is one of the markers. Next to albumin is also considered as a marker for severity. Just like you do the troponin for cardiac ischemia and myocardial infarction, prothrombin time and albumin are considered as the markers for assessing the severity of liver disease, whether it is jaundice or cirrhosis, whatever. And prothrombin time is considered more as an acute marker. It will decrease very rapidly within 24 hours once the disease is set in. Whereas albumin takes a long time. Why?
Half-life of albumin is 21 days, sir.
Excellent. It's a long storage is there. So half-life to decrease albumin, it takes at least 3 weeks. So it is a slow marker, but once it is established, that is also a good indicator of the liver disease. So the changes that happen in coagulation are prolongation of prothrombin time, loss of calcium, endotoxin-induced damage to factors 9 and 12 and platelets, low-grade DAC with increased fibrin degraded products, thrombocytopenia due to hypersplenism, and decreased absorption of vitamin A, D, K, E. So people usually talk only about this vitamin K, failure to absorb the vitamin K induced vitamins, but these other factors. So you must remember these 6 factors: prolongation of prothrombin time, loss of calcium, endotoxin, factors 11, 12, and platelets, etc. So apart from that, I have not gone into the details of the regular risk identification. What is the risk of, how did you stratify the risk in liver disease patient, whether it is jaundice or cirrhosis?
Childbirth classifications.
Cirrhosis.
CPT classification. So any liver disease functional problem, you can use the CPT classification, but MELD scoring will not apply here because MELD scoring is a main scoring system for deciding the liver transplantation priority. Okay, so you don't have to say about MELD or other scoring systems in this particular obstructive jaundice, but CPT scoring system is still valid because what are the parameters that you use to make the CPT scoring?
Serum bilirubin.
Ascites,
Hepatic
albumin,
encephalopathy, bilirubin, hepatic encephalopathy, prothrombin time,
and all this. So these 5 parameters are used for assessing CPT. So that is applicable for patient with obstructive jaundice also. Whereas other scoring systems which you use will not be applicable, and you should not say them for assessing the risk qualification in obstructive jaundice. And how do you manage this patient? Now this patient has a jaundice because of gallstone. So what is the management that can be done?
Sir, obstruction can be relieved either by minimally invasive.
Endoscopically or by open procedure. Okay, so
Yes.
you can do an ERCP and retrieve the stone, or you have to do a conduit procedure, remove the stone and put a stent and come out. So it can be endoscopic, or if it is endoscopic, what are the challenges?
Position, sir.
Nora.
It's a NORA.
NORA.
First answer is it's a NORA. It is done in the endoscopic suite, and patient may be in the lateral or in prone position and shared airway. All those problems which you normally find in the endoscopic suite of a PA gastroenterology department have to be described. But before that, you have to optimize the patient, assess the severity by using the CPT score. So CPT score classification, how do you group the patients?
Class
A, B,
A,
C.
B, C, D.
Class
CPT,
5
A,
to
B,
6,
C.
sir.
A is supposed to be the least dangerous
Score.
or the least affected. B carries little more mortality, and C carries even more severe mortality. Okay, so based on that, you have to plan that, and endoscopy can be done with a minimal sedation and gastro LMA, which can be used for maintaining the airway, and avoid all drugs which are metabolized in the liver. In any liver disease, you must make sure that you understand the drug metabolism also. So you have to avoid all the drugs which will suppress the, which cannot be eliminated by the liver and which will have a prolonged action if used. That is number one. And number two is you have to preserve the hepatic blood flow. That is the basic goal in any liver disease management, whether it is cirrhosis or whether it is jaundice, whatever be the condition. The main goal is to preserve the hepatic blood flow. And to preserve that, what are all the things that you have to avoid? What things can affect the hepatic blood flow, especially hepatic arterial flow? What type of ventilation can affect the hepatic blood flow?
Positive pressure ventilation.
Positive pressure with PEEP. Okay. So, and also hypoxia, hypocarbia, and hypotension. This also will affect that. Okay. So all those points you have to keep remembering. And that can lead to the question of control of blood circulation or blood flow to the liver, extraneous and intrinsic, extrinsic factors, all that you have to read up. Okay. So now another liver related case, 38 years old Mason with history of alcohol abuse for last 20 years, now comes with progressive distension of abdomen, swelling of legs and one episode of vomiting of blood. How to manage this patient? So first analyze the case.
Chronic alcoholic patient with ascites.
Pedal edema, hematemesis.
Apogee.
With liver failure.
Why
Decompensated.
hematemesis? What does hematemesis indicate?
Portal
Varicose
hypertension.
Portal
vein.
hypertension. That is the main thing. 20 years of alcohol abuse with abdominal distension, swelling of leg, probably alcohol-induced liver disease, which can be diagnosed as cirrhosis. Vomiting of blood probably due to ruptured esophageal varices, which is probably secondary to portal hypertension. What is the important history you have to elicit? Quantity of alcohol, okay?
Consumption, duration of alcohol consumption.
Swim per day, any IV drug abuse along with that, diet habits, nutrition, history of jaundice, any history suggestive of HIV, quantity and color of blood vomited because of the episode of vomiting. Then pre-op evaluation, investigation and risk classification.
So examination from head to toe.
Pre-op, look for evidence of cirrhosis or decompensated liver disease like poverty above and prosperity below. That is the classical appearance. The emaciated look in the upper part of the body and edema and the fullness in the lower part of the body. Any other portosystemic communications like in the rectum, any history of bleeding PV, bleeding per rectum, and any dilated veins around the umbilical called caput medusae. So these are the things that you have to look for. Pre-op investigations, you have to look for liver function test, CBC, RFT, EKG, echo, and coagulation profile. This stratification here you can use, because this is a cirrhosis case, you can use the CPT scoring system, ALB, adopt LC score. All these things can be used. And what is the management of variceal bleed and goals of treatment?
IV agents like octreotide.
Fairly precise.
Fairly precise.
And
Pharmacological
endovascular
treatment
banding.
and mechanical treatment or surgical treatment. Okay, that is how you classify that. So endoscopic banding, injection of sclerosing agent, balloon tamponade, or the interventional procedures. Pharmacological therapy with somatostatin analog like octreotide. And finally, tips. What is the expansion for tips?
Transnuclear intrahepatic
Portosystemic shunt. Okay, right. And the goals of treatment in acute variceal bleeding are to control initial hemorrhage, prevent early rebleeding, minimize deterioration in liver function, and treat complications associated with blood loss. So this is an acute emergency case scenario. So there is no need for talking about any anesthesia or anything here. So it is mainly to control the bleeding, and you prevent further worsening of the stenosis and try to reduce the portal hypertension by further aggravation of the cirrhosis. Then patient will be all right. Okay, so this is not an anesthetic management of any surgical procedure. It is more of a intensive care procedure where you have to know about these methods of managing this case. And there is an algorithm which has been described for bleeding varices. So first, hemodynamic stabilization, restrictive transfusion strategy if the hemoglobin is less than 7, antibiotic prophylaxis, initiation of vasoactive drugs, then upper endoscopy within 12 hours, and variceal source confirmation suspected. So endoscopic ligation can be done or managed appropriately as per the treating course. And so high risk bleeding, just few tips. I get whatever points I have told is given in the form of algorithm. So just for you to know that, so that in case they ask you, is there any algorithm you are aware of, and just say these are all the things that I have to give. This is just a picture of octreotide, how it is administered. You have two preparations. One is octreotide 100 micrograms, another is octreotide 50 micrograms of 1 ml. How do you administer that? Any of you given this?
In the infusion
So
form.
So it is IV bolus 50 microgram followed by 25 to 50 microgram per hour infusion for 5 days. That is the treatment for that. Right. We'll go finish this and have the other questions for the next class. So 22 years old primary gravida with 28 weeks of amenorrhea found to have a BP of 170 by 100 during antenatal checkup. A urine examination shows proteins 3+. Now patient complains of pain in the right iliac fossa. Posted for diagnostic lab and proceed. So what is the analysis of this case?
Sir, BP with 170 and 100 and urine examination protein shows it is a severe preeclampsia. Since the BP is more than 160/90, is
First of all, patient is a primary.
Pregnancy.
Which trimester she is in?
Second trimester.
Second trimester. That is the first point. So always go with that. So primary in early third trimester. I mean 12 into 12, 24. She is in the third trimester now, isn't it?
Yes,
And BP is high, protein in urine suggestive of pregnancy-induced hypertension, also known as preeclampsia. And patient has pain in right iliac fossa. Possible causes are non-pregnant related or appendicitis or twisted ovarian cyst, whatever may be. And possibility of premature labor, because if you do any intervention at this stage, there is a possibility of a premature labor and expulsion of the fetus. So these are the challenges in this case. What important history you should ask for? Because now you know that in the case of preeclampsia, what history you should ask for?
sir, whether it is already diagnosed or it is
Antenatal, whether the patient has come for regular antenatal checkup, when she was found to have high BP, and whether she is on any medication, and despite the medication, if the BP has gone up, so thorough antenatal history should be evaluated. Okay, history
Yes, sir.
pertaining to PAH and pregnancy, and in relevance to non-obstetric complaint about this right iliac fossa pain, how long it has been there, whether there is. Can you check the McBurney's tenderness to rule out appendicitis in this case?
No, sir.
No, sir.
Why?
Because it is a gravid uterus.
Anatomical landmarks are
Yes.
distorted now.
First,
Okay?
it will come around the umbilicus, then it will spread to right iliac fossa.
Right iliac fossa, but normally you are supposed to press at the point connecting the umbilicus to the anterior superior iliac spine, divided into three parts. The medial 2/3 joining with the lateral 1/3. That is called the McBurney's point. So that will be distorted when my lady is 28 weeks old. So McBurney's point tenderness may not be fully elicited in this case. So how do you diagnose the abdominal pathology?
Ultrasounds.
Ultrasound. Everything now ultrasound. Okay. And the general examination and systemic examination has to be done. What are the pre-op investigations you have to do?
So routine investigations along with
Fetal hormone.
complications of preeclampsia, like fundus examination, renal function test,
Good. So assess the
and ultrasound. Yes.
preeclamptic state and assess the non-obstetric surgical problem. Okay, that is how we can do the investigations based on that. And then risk stratification based on because of the preeclampsia, mild, moderate, or severe. What is the pre-optimization? Need for tocolytics has to be thought of because there is a risk of premature labor. What are the tocolytics that can be used?
Magnesium sulfate.
Nifedipine
Nifedipine
can be the
and-
drug of choice.
Nifedipine.
Patient has high BP also, so.
Sir, magnesium sulfate is the drug of choice because it acts both.
Magnesium sulfate
periods.
mainly to prevent seizure as a seizure prophylaxis, but that also will have a tocolytic. But what is the most specific and most effective tocolytic?
Clozapine.
Prostaglandin.
Beta agonist.
Terbutaline.
Steroids.
Any inhaled agent?
Salbutamol.
Beta 2 agonist. That is a very fast acting and easy to administer also. Okay, that is a very important drug that has to be thought of. And pre-op instructions may be semi-emergent or elective, depending upon the severity of the surgical pathology. So if it is semi-urgent, what is your plan of anesthesia? If it is elective, what is your plan of anesthesia? What is the difference between these two conditions?
Sir, for elective, we can have
NPO guidelines can be given or not?
so we can give anyway. She's more than 20 weeks. We'll be giving rapid sequence.
But at least we can guide her not to take anything. But in
Yes.
semi-emergent, it is the risk is more. The risk of full stomach is more in semi-emergent compared to elective, isn't it?
Yes, sir.
Because in elective, we know that she is not taking something, even though all pregnant women are considered as full stomach patients. The risk is more in semi-emergent. That is number one. So, what is the prophylaxis that you will give for acid aspiration? What is
Proton
the
pump
trinity?
inhibitors, H2 blockers,
Hmm.
metoclopramide and sodium citrate 30 minutes before the use.
So these three things, you have to give a H2 receptor blocker, you have to give a prokinetic agent, and you have to give a antacid in the form of 0.3% sodium molar citrate. Intraoperative management, special reference to fetal monitoring, that has to be taken care of. So the choice of anesthesia, continuous seizure prophylaxis with magnesium is the an important thing that has to be. So we have to prevent any seizure attack happening. Okay, so these are all the points. This is a common question scenario with a incidental problem. Second week of pregnancy is always safer for any intervention, but the third week, this is the greatest danger, is the premature labor. Okay, so this is how the questioning can be done in that, and this sort of incidental surgical conditions coming for surgery, don't forget about premature labor in these cases and the need for tocolysis. That is the main point that is expected out of it. And if it is complicated by the preeclampsia, you must know everything about management of preeclampsia in the antenatal as well as intra and post-op period. So the questions can be totally on patient with PET coming for anesthesia and surgery. So we'll stop here today because there are another 10 more scenarios are there. And, I don't want to load you with too much of this problem today. So I will stop here. Since you all have another this next month, 19th and 20th is only the exams dates as Risha informed me. So we have one more week for you to learn that. So if you are happy, we will continue and have the next class where we will complete all the rest of the cases.
Yes, sir.
It's okay?
Yes, sir. Yes, sir.
Right.
Any doubt?
Any
Thank you,
doubts or
sir.
any?
Thank you, sir.
Hope you got
Sir,
some
there are
idea
two
about how
questions.
to answer and or how to go about with the long cases. So, those who attended recently the FAT exam, Soundarya, did you present in this way? Because this is the way we have been discussing long cases in the classes.
Yes, yes, sir.
How was
I
the
presented-
examiner's reception about this presentation? Were they agreeing for that or they found fault with that?
Sir, I presented pregnancy topics, sir. So I presented like this way only, sir.
Because I don't know how many examiners are in the habit of agreeing with the presentation like that, but I thought this way you will not forget any points so that you can
Yes, sir.
practice in such a way and the presentation will also be quite appealing to the examiners. That was with that idea only I prepared the things like this. So hope it is working out and I'll see you in the exam also. Okay?
Yes, sir.
Yes. Shall we
Questions
sign
were
off?
asked during the class, sir. Two questions were asked during the class, sir. One is
Okay.
why this Brahma Muhurta high incidence of myocardial infarction post-operatively. So
The answer is
students-
this early morning period is supposed to be the time where the fluid shifts are happening a lot of time thing in the early morning period. That is 3 to 6. The second thing is patient has been given some analgesic for a good sleep and they don't feel that pain of ischemia and So these are the two reasons attributed for this. So they go in for silent ischemia and infarction. And the nurse usually will come and tell you, I went to give a sponge bath in the morning and I found the patient dead, because they don't call you or call the nurses for pain and all that. So the two reasons attributed for this early morning is, one is the heavy fluid shifts that happen. The second is the analgesia that is provided for the good night's rest. What is the other question?
Point I want to ask you, sir. In Miller also, they have added the incidence of postoperative arrhythmia as a common complication, and happening is also very common, highest incidence in the first postoperative night. Because of the stress response due to surgery and recovery. And as you said, the pain is also stimulating cause. And the other question is CNS complications related cerebral abscess in a top patient, the choice of anesthesia.
The choice of anesthesia, of course, is GA, because it usually occurs in children. And but the management has to be done between preventing a rise in ICP and preventing an increase in the right to left hand. These are the two things, the basic goals for that. So to prevent ICT, even though ketamine is considered as an ideal induction agent for patients with tetralogy of Fallot, which will raise the SVR to prevent the increase in right to left hand. But giving straight away ketamine as an induction agent will raise the ICP also. So it is not the ideal agent as a sole anesthetic agent, but a combination of ketamine and propofol, which is called ketofol, is supposed to be a good agent where it will preserve the SVR also, at the same time preserve the rise in, prevent the rise in ICP. So ketofol for induction, with avoiding the laryngoscopic intubation response by your xylocard, and then maintaining anesthesia with preferably morphine as an agent to dilate the pulmonary vasculature, and giving what is called a scalp block with infiltration all around the skull, I mean the forehead to the occiput, which will give a good pain relief for the craniotomy procedure, and asking the surgeon to infiltrate into the periosteum and dura, and then they can just go in, and if they know the location correctly, the surgery will hardly take about half an hour or so. So with this method, we can easily manage the whole procedure. And of course, controlled ventilation with cisatracurium, and with a higher percentage of oxygen all the time, and monitor the saturation and other parameters as usual.
Yes, sir. Thank you very much, sir. If no further questions, can we sign off this meeting, sir?
Okay, right.
Thank you very much, sir.
Thank you,
Thank you,
sir.
sir. Thank you, sir.
Good night.
Thank you, sir.